Hi, my name is Dr. Jasmine Thum. I'm one of the neurosurgeons here at UAB. I've made this video for you so that you can understand some of the more common procedures that I tend to do. I practice epilepsy surgery, functional neurosurgery, stereotactic neurosurgery, and reanimation of limbs after a spinal cord injury, brachial plexus injury, or an injury to the nerves themselves. In this video, I will be reviewing stereotactic electroencephalography, or stereo EEG, or sEEG for short. This is a procedure in which we try to localize where in the brain your seizures are coming from. It is more invasive than the scalp EEG that you may have undergone in the epilepsy monitoring unit with your epileptologist. Before you see me for epilepsy surgery, you'll be seen by one of our excellent epilepsy neurologists here at UAB. We have 17 providers who see adult epilepsy patients here at the University of Alabama. In this video, I will be going through a variety of items, including your preoperative visit, your operation, your care after the surgery, and your stay in the epilepsy monitoring unit, and then your postoperative care when you go home. To start with, when you see me, you'll have already been seen by your epilepsy provider. We will have formulated some sort of a plan as to where we think the epilepsy is starting in your brain. We do this at a joint conference that we hold. At this multidisciplinary conference, we have your epileptologist on the medicine side, your epilepsy surgeon, myself, a radiologist who reviews imaging with us, as well as a neuropsychologist who goes over your neuropsychiatric tests that you'll undergo. This will help us determine where your memory, language, and other important functions are mapped into your brain. Once we've decided where we think the seizures are likely coming from in your brain, there are a few options. One, we can go ahead and proceed to a resective surgery. If we're unable to localize exactly where the seizures are coming from in your brain, we'll proceed on to stereo EEG. This will give us a better idea of where the seizures are coming from in your brain so that we can offer you a more targeted solution. Sometimes we will stick the electrodes all on one side of the brain, but in different parts or different structures of the brain. In other cases, we might be concerned that the seizures are coming from both sides of the brain, in which case we'll implant electrodes on both sides of the brain. The electrodes are very small. They're about the diameter of a piece of spaghetti or smaller. They are placed into the brain through a very small hole that's just slightly larger than the diameter of the electrode. This small hole is then capped with a screw and a cap on top of the screw to keep the electrode in place. You may have anywhere from about 5 to 25 electrodes that are placed in your head, either on one side or both sides. You will see the cap protruding from the top of your scalp, but there will only be a very small incision in the scalp in order to place each single electrode. Here are some pictures of what this looks like. You, however, will not see this after the surgery. After the surgery, your head will be wrapped in a turban similar to this. This is to ensure that the electrodes stay in place throughout the duration of the monitoring stay. Your monitoring stay will be very similar to your monitoring stay in the epilepsy monitoring unit for scalp EEG. The surgery itself takes anywhere from 4 to 6 hours, depending on how many electrodes we need to place. You will usually come in at 5 a.m. for a 7 a.m. first start case. We ask that you take all of your epilepsy medications that you take in the morning before you come into surgery. So I would recommend taking them first thing when you wake up in the morning. Please take them with only a very small sip of water. That way you don't risk aspiration or some of that fluid from your stomach going into your lungs during the surgery. In order to decrease your risk of bleeding during surgery, I'll also ask that you stop any blood thinners or antiplatelet medications 7 days prior to surgery. We'll continue to keep these off until 7 days after your last surgery as well. So that would be after the explant of the stereo EEG. Examples of blood thinners include aspirin, warfarin, Coumadin, Plavix, heparin, and others. I also ask that you do not take any NSAIDs or non-steroidal anti-inflammatory drugs for pain before surgery as well. The reason I ask this is because they also have a small risk of increasing the risk of bleeding. These NSAIDs include things like ibuprofen, naproxen, and we ask that you only take Tylenol if you need it for pain control 7 days before surgery. You will be intubated for the surgery, meaning that you'll have a tube placed down your throat to help you breathe. This will be done under general anesthesia, so you will not be aware of any of this part of the procedure. You will also have a Foley catheter, or a small tube that will be placed in through your bladder to help you void or go pee during surgery. This Foley catheter is usually kept in place after surgery as well and will be removed the following morning around 6 a.m. Generally speaking, it is not that uncomfortable for it to be removed, and most patients say that they feel a sensation of urinating when the catheter is removed. The reason we keep this catheter in overnight is so that you don't have to get up and rush to the bathroom right after a brain surgery. After you are intubated and a Foley catheter is placed, we will go ahead and place a head frame on your head. This head frame again is done only while you are completely asleep. You might notice 2 small pin sites when you wake up, one above each of the eyebrows and 2 in the back of the head. You might have small staples or sutures or a bandage that is covering up those pin sites to prevent them from bleeding after surgery. They are very small and they heal very well. The reason I place this frame is so that I can navigate to exact locations in your head. I aim for sub-millimeter precision for placing these electrode leads, and in order to do that, we need to make sure that your head stays very still during surgery. I also use a robot called the ROSA robot in order to place the electrodes. It helps guide me on the exact location of the placement for these electrodes. And then I place them by hand after the electrode has been guided to the appropriate position by the robot. In order to place the electrodes, I do not need to do a large head shave. In fact, I rarely need to shave hair for the placement or removal of these electrodes. The major risks of this operation include bleeding and infection. The risk of bleed is anywhere from about 1 to 3% depending on how many electrodes are placed. With each additional electrode that's placed, there is about a 0.1% increase in the bleeding risk for this surgery. If you have high blood pressure or any vascular malformations in your brain, this can slightly increase your risk of bleed during the procedure. If you do have high blood pressure, this is something that we will control during the surgery to ensure that we decrease this risk. The risk of a major bleed happening during the surgery, namely something that could cause noticeable symptoms for you, is about 1 in 1,000. These symptoms may include difficulties with speech, movement on part of the body, or even sensation on part of the body. We'll get a low-resolution CT scan after I've placed all the electrodes to confirm that they're in the appropriate position. But unfortunately, this is not high resolution enough for me to tell whether or not there has been a small bleed during surgery. If only a small bleed has occurred, something that wouldn't be noticeable for you or cause any symptoms, then I will be able to pick this up on a post-operative CT that we get once you've been woken up and taken to the post-anesthetic care unit, or the PACU, after surgery for recovery. Once you're in the PACU, we will go ahead and get a full CT of your head to make sure that there are no small bleeds. If there are any bleeds that I'm concerned about, I will make sure to let you and your point of contact know. I will always go ahead and call or talk to in person your point of contact for the day of surgery after the surgery has been completed to let them know how things went. When I see you in clinic, please let me know who your day of surgery contact will be and please provide me or one of my advanced care providers, such as my PA or NP or nurse, with their number. One of the other major risks of this operation is infection. Things that can increase the risk of infection include a history of diabetes, previous infections with surgery, or any difficulties with wound healing in general. This can include chronic use of steroids or other rheumatologic medications that we might need to stop before surgery. In order to decrease the risk of infection after the electrodes are placed, I will place you on antibiotics after surgery, and that will continue until the electrodes are removed. We also will get labs for the first few days after surgery to make sure that markers of infection, such as your white blood cell count, have not been increased. If you end up staying in the epilepsy monitoring unit for a long period of time after the electrodes are placed, we can go ahead and start spacing out the labs so that you're not having them done every day. Once we have obtained the head CT and the PACU, I will go ahead and review it. If there are any bleeds that I am concerned about, we will admit you to the ICU or the intensive care unit overnight. If I'm not concerned about the findings, we will go ahead and admit you to the epilepsy monitoring unit, which is a floor bed that will be available for you that night. We will get you hooked up to the monitors, and we will start recording from the electrodes that evening. We will be monitoring any electrical activity from the electrodes during your stay. We will slowly wean off your medication. The neurology team will be involved at that point forward. They will help wean off your epilepsy medications slowly so that you don't have a generalized large seizure while you're in the hospital. We do want to try and capture any partial seizures or focal seizures that you might have, as this gives us better data as to where the seizures are coming from. We usually like to capture about 3 seizures that are typical for you while you're in the hospital. If you're not having any seizures by about the second week, we can go ahead and use other methods to try to provoke seizures. These methods include things like depriving you of sleep, exposing you to bright or flashing lights, providing small amounts of electrical stimulation to the brain, or even potentially giving you some medications. You should expect that most of your seizure medications will be weaned off by about the 7th to 10th day in the epilepsy monitoring unit, or EMU. Of note, I will see you almost every day that you're here in the hospital, regardless of your length of stay. The attending on the neurology team may or may not be your primary neurologist. They switch out every week, switching every Monday. I will continue to talk with the neurologist who's on service, regardless of who they are, about your care. Once we've decided that we've collected enough relevant data, we'll go ahead and remove the electrodes. The removal of the electrodes is a very short procedure. It usually only takes about an hour to remove all of the electrodes. You will have a small suture that will be placed in each of the electrode sites to close it up. It'll have a small tail on it so that we can find it later if we're concerned about any sort of infection from a point source on your skull. These sutures, however, are absorbable and should fall out on their own. If they don't fall out, you will be seeing us in clinic in about 2 weeks' time, either with myself in neurosurgery or your neurologist, and we can go ahead and remove the remaining sutures that are still in place. Unlike your first surgery, which is a scheduled surgery that starts first thing in the morning, for the electrode removals, it's usually based on OR availability since we cannot necessarily predict what day we will remove the electrodes on. Because of this, we will still need you to stop eating or drinking after midnight the night before the electrode removal, even if it's in the afternoon, as this will give us an opportunity to move you earlier into the day in case a spot opens up. If we're able to remove your electrodes first thing in the morning, you can usually go home after surgery that same day. Again, I will get a head CT just to ensure that there have been no small bleeds created with the removal of the electrodes. If we can't remove your electrodes until later in the day, usually I'll go ahead and discharge you the next day. Most patients have to have some electrodes that are placed very low in the temporal lobe, about right here on the skull. Those electrodes can be irritating for many patients. The reason they're so irritating is because it goes through what's called your temporalis muscle. This is one of the large muscles that you use for chewing. Because it can get irritated from the placement of these electrodes through the muscle during surgery, I oftentimes will have patients start on a soft diet for the first 3 days after surgery. This includes things like jello, ice cream, mashed potatoes, and other well-cooked or soft foods in order for some of the inflammation in that muscle to decrease. We can get you started on a regular diet as soon as you're comfortable with it. Therefore, if you have difficulties opening your jaw after surgery, or if you have difficulties with pain due to speaking and opening your jaw, this is something that is to be expected the first few days after surgery. Usually the pain goes down by around day 3. Most people will also experience some sort of a headache after surgery. This is very common. We will give you pain medication while you're in the hospital, as well as anti-nausea medication, because the anesthetics that we use can sometimes cause significant amounts of nausea or even vomiting in patients after surgery. The pain medication that we give is IV and oral for the first couple of days. We usually like to limit the IV medication that we give in the long run and limit it to oral medication only. I will have you on Tylenol around the clock, meaning scheduled Tylenol, for the first 3 days to try to decrease any amounts of inflammation that we have from the surgery that might be causing headache or pain. Usually, the headache is worse on the second day or the third day after surgery, as much of the medication that we gave you during the surgery under anesthesia will start to wear off around 24 hours after the surgery. So if you experience an increase in your headache or pain at that time, that is something to be expected. I do like you to have some movement while you're in the hospital to avoid blood clots. I would like for you to sit at the bedside in the chair as soon as possible, and I'd like you to get up and walk to the bathroom also when you're feeling comfortable. We'll also give you a medication, a shot, usually in your abdomen or in your thigh, while you're here in the hospital to prevent any blood clots from forming in your legs that could travel to your lungs or your heart or your brain. It can be frustrating staying in the epilepsy monitoring unit for a long period of time. Patients stay there anywhere from 5 days to about 4 weeks. If we can't get any seizures elicited after the 4-week time period, we will have a discussion with you and we might elect to remove the electrodes even though we haven't been able to capture any relevant data. Please plan ahead that you might be in the epilepsy monitoring unit for up to that 4-week time period. Please bring a variety of things to keep you company, whether that's books or other human beings. The neurology team likes for you to have a family member at bedside for most of your stay in the epilepsy monitoring unit. We know that this can sometimes be difficult to arrange, and if you're having issues getting this kind of support, please go ahead and contact our epilepsy coordinator who can help you figure out how to best address this when you're in the epilepsy monitoring unit. At UAB, because we are a large teaching and research facility, we also have a variety of research protocols that can be conducted in the hospital. If you're interested in being part of any of the research studies, please let me know. Sometimes we'll go ahead and approach you and ask if you'd be interested in any particular studies while you're in the epilepsy monitoring unit. These usually consist of a variety of small tasks that engage your brain in different ways, and we can measure the differences in your brain's response with the electrodes that are in place. We don't have to place any new electrodes in order to do any of these studies, and it's simply just some small tasks that you can do while you're in the hospital to help pass the time. If you definitely do not want to be involved in any research studies while you're here in the hospital, please let me know at our clinic appointment. Once we have determined that we have all the data that we need, we will start you back on your epilepsy medication again. After the electrodes are removed and you've been discharged from the hospital, I ask you to continue to take Tylenol for 3 days, every 6 hours when you're at home in order to prevent, again, any significant headache after the removal of the electrodes. Usually the headache after the removal of the electrodes is not as significant as the headache that occurs with the placement of the electrodes. Again, I ask that you do not take any NSAIDs for 7 days after the removal of the electrodes, and I also ask that you do not take any blood thinners or antiplatelet medications, such as the ones mentioned previously, 7 days after the removal of the electrodes, in order to decrease the risk of bleeding after surgery. You will not have a dressing in place on top of the sutures, and I ask that you just keep it clean and dry after surgery. Please do not get your scalp wet for 3 days after surgery. I try to wash your hair as best I can at the second surgery at the time of removal of the electrodes so that you don't have as much residual buildup in your hair when you go home. However, please do not wash your hair at home for 3 days after the removal of the electrodes. You are free to wash your body during those 3 days. After those 3 days, you're welcome to shower your hair. I ask that when you dry your hair off, you pat dry and try not to rub any of the incisions. I also ask that you don't submerge your head underwater in baths, pools, or other standing bodies of water for the first 2 weeks after surgery. This allows those incisions to heal well and decreases the risk of infection after surgery. If you want to dye your hair, please do not dye your hair or use harsh chemicals on your hair for 4 weeks after surgery. After your stereo EEG stay in the hospital, you will be seen by your primary neurologist. At that time, we will all have discussed the data that we collected while you were here in the hospital. Your neurologist will make recommendations as to what the next steps should be. After your stage 1 sEEG procedure, we will discuss your second stage or stage 2 surgical intervention in order to finally address or treat the seizures that you're having. Please remember that stereo EEG is not meant to treat your seizures. It's simply meant to localize where the seizures are coming from in your brain. Stage 2 is meant to actually address and decrease the number of seizures that you're having. Some patients can be seizure-free after some of these surgeries. Others are not. If we cannot determine where the epilepsy is coming from in your brain, it's possible that we have to go through another round of stage 1 stereo EEG in order to better capture some of the signals that are coming from your brain. This rarely occurs, but there is about a 1% chance that we aren't able to capture some of this information, and we do have to repeat the stereo EEG. You can, of course, elect whether or not you'd like to proceed with doing stereo EEG again in this case. At that point, there are usually several different ways that we can address seizures. If we have been able to identify a specific focus where the seizures are coming from the stereo EEG procedure, we can then go ahead and address it through either a removal of the tissue, through an open craniotomy, through an ablation of the tissue, through what we call a LITT procedure, which is laser interstitial thermal therapy, or we can go ahead and place a neuromodulation device, such as a responsive neurostimulator, into the brain. An open craniotomy is the most invasive approach. However, it also usually offers the greatest chances of seizure freedom in well-selected patients. In this approach, I make a large incision on the scalp and shave some of the hair around it. I then go ahead and remove some of the bone so that I can access the brain. I remove the tissue that's causing the seizures, and then go ahead and plate and place the bone back on the skull, and then go ahead and close up the incision. Usually the incision will be closed with staples, unless this is a second or redo surgery, in which case it will be closed with sutures. Both of these will be removed at 2 weeks after the time of surgery. The recovery time from an open craniotomy is usually a few days in the hospital, about 2 to 3 nights stay. Sometimes a drain is placed, and the length of stay can be limited by the amount of time needed to drain the fluid from the brain. Once you're discharged home after a craniotomy, it can take about 2 to 4 weeks for most patients to feel back to normal again and get back to work. If we elect to do LITT or an ablation instead, what we do is we place a minimally invasive probe into the head, and we burn the tissue that's causing the seizures from occurring. We cannot do this in all patients, and there's a slightly lower efficacy rate for resolving seizures in patients with this approach. However, the recovery from it is significantly shorter than an open craniotomy. After a LITT procedure or a minimally invasive ablation procedure, we can usually discharge you the second day. We will discharge you on a course of steroids that you will take at home. This is to prevent any inflammation or swelling after the surgery. Sometimes you can have a peak in headaches 2 days after the surgery, since most of the anesthesia has worn off, and there is increased swelling at around the 2 to 3 day mark after the tissue has been burned. We'll give you medication for you to take at home for the pain. Usually this is a combination of Tylenol and some low-dose narcotics. Try to limit the amount of narcotics that you take as much as possible, since it can cause severe side effects such as constipation, as well as cognitive slowing that can lead to falls and imbalance that can also lead to falls. Again, I want you to take Tylenol for 3 days after surgery around the clock, meaning every 6 hours, in order to decrease the amount of swelling and pain associated with the procedure. If you have any liver issues, please let me know, as this can affect the Tylenol dosing that we prescribe. The third option is neuromodulation. This can be used if there's a specific seizure focus in the brain, and also if there are potentially several seizure foci in the brain. There are 2 different types of neuromodulation depending on if there's a single seizure focus or if there are many seizure foci. One type of neuromodulation, meaning electricity applied to the brain in low voltages in order to try to decrease the number of seizures that you're having. Neuromodulation is where we place a permanent lead, similar to the leads that are placed in stereo EEG. However, this one remains permanently inside of you and is attached to some sort of a battery that also gets placed underneath your skin, either under your scalp or underneath your collarbone in your chest right here, in the same position that a pacemaker is usually placed. This device will send a small amount of electrical current to a particular part of the brain in order to try to stop seizures from occurring. One of the modalities that we use for neuromodulation is responsive neurostimulation. This type of neurostimulation fires only in response to epilepsy activity or seizure activity that it picks up in a specific part of the brain. This device usually has anywhere from 1 to 4 leads that are placed. Those leads then can be connected to a battery which is placed inside of the skull. A small part of bone is removed from the skull and a tray is placed into that area where the battery then sits in it. This battery can be connected to up to 2 leads at a time. Sometimes we will add additional leads so that we don't have to come back and do the whole surgery again if we're concerned that there's more than 2 foci that are causing the seizures from occurring. That way, if we want to go ahead and test the other seizure foci, we can go ahead and just open the incision on the scalp to the battery, remove the 2 electrodes that we were previously using, and plug in any other electrodes that we might have already placed. This is a less common approach. Usually only 2 electrodes are needed for most patients. In the case of responsive neurostimulation, the battery again is placed inside of the skull. The battery usually lasts anywhere from 3 to 7 years, depending on how much the battery is being used for seizure activity. The more seizure activity you have, the more it fires, and the shorter the battery life is. If you have a device that is placed, you will also be given the contact information for the device representative who can help you troubleshoot any issues that you might have with the device or learning how to use the device at home. For responsive neurostimulation, or RNS devices, we use the company called LivaNovo. The second type of neurostimulation that we use is deep brain stimulation, or DBS. If we're concerned that you have more than one focus in the brain that cannot be easily accessed, we will go ahead and use deep brain stimulation instead to help control your seizures. This is targeted usually at a location in the brain called the thalamus. The thalamus is a structure deep in the brain and is a large relay station for a lot of the electrical activity that's going through the brain. The thought is that by stimulating this part of the brain, we can decrease the seizures from spreading from one part of the brain to other parts of the brain. This can potentially decrease the number of seizures that you have, the seizure intensity that you have, or even change the seizure types that you have. Deep brain stimulation will usually include the placement of 2 electrodes. These electrodes are usually somewhere on the frontal part of your skull, usually in this location and this location, just behind the hairline. I will need to shave a small portion of hair in order to place these electrodes and to ensure that there is no hair that gets in the incision causing any sort of infection. I do not need to shave the whole head in order to place deep brain stimulation electrodes. Deep brain stimulation neuromodulation is the only procedure that is actually done in 2 stages here at UAB. The first stage is the placement of the electrodes. Those will be done usually on a Monday, and then you will have the second stage, which is the placement of the lead extenders and the battery that's placed in the chest on a Friday. If you'd like to learn more about deep brain stimulation, I have a separate video about that for my patients who undergo functional deep brain stimulation for movement disorders. Much of the information in that video will also apply to patients who are undergoing deep brain stimulation for epilepsy as well. The only major caveat is that deep brain stimulation for epilepsy surgery is done asleep instead of done awake. For deep brain stimulation, or DBS, we use a variety of different companies, including Medtronic, Boston Scientific, and Abbott. The type of device that will be used for you depends on a discussion that I have with your epilepsy provider. Sometimes in patients who we cannot find a seizure focus for, we can also offer one other intervention for epilepsy. This is called a vagal nerve stimulator. Vagal nerve stimulators are a small paddle or electrode that's placed around one of the nerves in your neck called the vagus nerve. The vagus nerve travels from your brain to your body and innervates your heart and your gut and some of the other organs. This particular nerve is thought to, when stimulated, actually decrease the number of seizures that you're having. When you have a seizure, you will be given a wand that will go over a battery pack that is placed in your chest, and when you are having a seizure, you wave the wand, or somebody else waves the wand over your chest in order to try and stop or abort the seizure from occurring. The vagal nerve stimulator device is very small. It's usually only about an inch long. It gets placed about 2 finger breadths below the clavicle in the skin underneath your chest on the left side. If you've already had a device placed on the left side of your body, or you've had a surgery on the left side of your body, please let me know in clinic. All of these second stage surgeries, meaning an open craniotomy, LITT, RNS, or DBS for neuromodulation, take about 6 hours to complete. This includes anesthesia time. All of these procedures will require again the placement of a frame. However, you will again be asleep for the placement of the frame in all of these procedures. Craniotomies will usually require about a 2 or 3 night stay in the hospital. LITT usually only requires 1 day stay in the hospital. RNS or DBS usually requires about 1 to 3 nights in the hospital. Recovery time from a craniotomy is usually the longest. It can take about 2 to 4 weeks for you to feel like you're back to normal and able to return to work. For a LITT procedure, you again might experience pain, such as a headache, that peaks at about the second day, but most folks can get back to work at around 3 to 5 days after the procedure. After a deep brain stimulation placement or a responsive neurostimulation placement, you can usually return to work within about 1 to 2 weeks. Placement of a vagal nerve stimulator usually only requires 1 overnight stay in the hospital. You can then go home the next day. Pain is usually pretty minimal unless you already have another sort of pain disorder or if you use very high amounts of narcotics at home at baseline. If you have a neuromodulation device placed, such as a DBS or an RNS, this will be programmed after placement by your neurologist. After surgery, you'll return to my clinic and see me or one of my nurses 2 weeks after surgery in order to look at the incisions and make sure that your incision is healing well. Sometimes we will need to remove staples or sutures at this visit. I will then see you again at the 3-month mark just to ensure that everything is going well. After surgery, your neurologist on the medicine side will continue to manage your epilepsy medications. They will also go ahead and manage any of the programming for your neurostimulation device if one is placed. If you have any issues after surgery relating to the procedure or the surgery itself, please reach out to my office. Main warning signs that I want you to look out for are a severe new headache that changed a few days after the surgery and is not improving. I also want you to be aware of significant nausea or vomiting that starts after the surgery. I also want you to be aware of any signs of infection when you go home. This includes significant worsening redness of the incision, worsening tenderness of the incision, worsening of fluid buildup underneath the incision, or any pus that is leaking out of the incision itself. For the first couple of days, there will be what we call some serosanguinous, or basically thin liquid that seeps out of the incision. However, this should stop by about days 3 to 5 after surgery. If you ever see any large amounts of clear fluid leaking out of the incision 3 days after surgery or more, please alert my office and let us know. If you have any concerns about damage to the device, if you had a device placed, please reach out to my office and let us know. You can reach my clinic anytime at 205-934-7170. You can also contact myself or my nurse through the portal anytime. I very much look forward to meeting you in clinic and to starting this journey with you. As you watch this video, I encourage you to write down any questions that you might have and bring them into clinic so we can discuss them at the time.